So everyone who is celebrating. We're very excited to have two leaders in public health with us here today. They're joining us as a part of our Innovators in Health Equity and Racial Justice Speaker Series, and they're also joining us as a part of our events to commemorate National Public Health Week, which we're in the middle of this week as well. So it's a true pleasure to introduce Dr. Bisola Ojikutu. Dr. Ojikutu is a nationally recognized physician leader, health equity researcher, community advocate, and expert in prevention, care, and treatment of infectious diseases. Dr. Ojikutu was appointed executive director of the Boston Public Health Commission in September 2021, and she also serves as the Commissioner of Public Health for the City of Boston. As the executive director of the Boston Public Health Commission, the city's health department, Dr. Ojikutu manages a budget of $162 million and leads a department that has over 1,200 employees, all working to protect, preserve, and promote the health and well-being of all Boston residents, particularly those who are most vulnerable. Dr. Ojikutu is a key advisor to Boston's mayor on health issues and builds innovative partnerships across city departments and within Boston's communities to positively impact the health of all city residents. Among her public health priorities, she is committed to addressing racism as a public health crisis and advancing health equity. Dr. Ojikutu is an associate professor of medicine at Harvard Medical School and a faculty member within the Division of Global Health Equity at Brigham and Women's Hospitals. She also holds appointments within the Division of Infectious Diseases at Mass General Hospital. Dr. Ojikutu also has significant international experience. As a senior advisor at Johnson Incorporated, Dr. Ojikutu directed a $30 million project that provided program management, strategic planning, and technical assistance to improve HIV care and treatment to 15 countries in sub-Saharan Africa and Latin America. She is also the former director of the Office of International Programs at Harvard Medical School. Dr. Ojikutu graduated from Johns Hopkins School of Medicine. She completed her internal medicine residency at New York Presbyterian Hospital, Cornell, and infectious disease fellowship at Mass General Hospital and Brigham and Women's Hospital. She's a former Commonwealth Fund Fellow in Minority Health Policy and has a master's in public health and health policy and management from the Harvard School of Public Health, another up-and-coming school just up the road from here. She is board certified in internal medicine and infectious diseases and is a fellow of the Infectious Disease Society of America. We also have, speaking today, Triniese Polk. Triniese is the director of the Office of Racial Equity and Community Engagement at the Boston Public Health Commission. For more than 20 years, Triniese has advocated for racial and social justice, leading many transformative initiatives in Boston and at the Boston Public Health Commission. While in her current role, Triniese established the Health Commission's first community-driven anti-racism policy, which operationalizes cross-departmental equity and inclusion standards of practice. In response to Boston's Racism as a Public Health Crisis Declaration, Triniese and her team established the Boston Public Health Commission Generational Health Scholarship Program for BIPOC identifying students seeking careers in fields including public and mental health, medical, and dental. Triniese holds a Bachelor of Arts in Human Services from Springfield College and a Master of Science degree in Health Communication from Boston University. So without further ado, it's a pleasure to welcome Dr. Bisola.
And for inviting me to join you today. Before I get started, first of all, I want to say a word just about Triniese because her bio didn't really say enough, I think, about her work. I mean, when I was first appointed, executive director, most people said, well, you have to meet the queen of BPHC. I didn't know it was hard. So I met Triniese and I realized she is the queen of racial justice, community engagement, community mobilization, community empowerment, all of these things within the Boston Public Health Commission. She led so many efforts around the city and she does it without a lot of fanfare. So I just really want to appreciate the kind of people who we have working within our Boston Public Health Commission. So as Neil said, this is National Public Health Week, really exciting week for us to amplify and uplift all of the great contributions within public health. from key interventions that have extended life expectancy. So we're talking childhood immunizations, we're talking clean water, we're talking about seatbelts, and all the things that we're doing to link social and structural determinants of health with poor health outcomes. I mean, this is the time, this is what we should be doing right now. So then if public health has done such great things, then why am I trying to reimagine it? You know, why am I calling this presentation Reimagining Public Health? Well, I think most of you all probably realize that public health has in general been underappreciated, it's been undervalued, and it's been underfunded. And we need to do something different. We need to do something different about that. I do not think that we're going to ever be able to truly advance health equity, to truly address structural racism, unless we actually do something to do something better and uplift public health. So that's why I want to reimagine public health, particularly here in Boston, because I believe that a lot of what needs to be done is actually needs to be done at the city level, it needs to be done at the city health department, it needs to be done within communities, and that's what we're going to talk about today, okay? So before I get into that, Neil mentioned that I've done a lot of work internationally. So I just want to tell you just a little bit more about myself. That way you understand my perspective, you understand sort of how I see the world, because that's a large part of this reimagining. So my career actually began in international health. After I completed some training, I moved to South Africa and I started working with the MGH National Hospital Harvard PEPFAR program. And so it's basically to jumpstart a lot of that. And if you all know anything about PEPFAR, I'm dating myself, so you can probably calculate how old I am at this point. That's okay though, I'm proud of these years. And honestly, it was a great experience for me, but it was also painful. You know, I was a young Black physician, young Black female who was trying to lead, teach, move an agenda forward in a setting that was still rife with gross inequity at a time that was really quite proximal to the end of apartheid. I mean, it was right around 2002, 2003, so that's not even 10 years post-apartheid that I was working there, but really rewarding. And I learned a lot from being alone in that environment and trying to move an agenda forward and doing it against the grain. I ended up actually staying in sub-Saharan Africa for an extended period of time and kind of flying back and forth. I worked in about 15 different countries in sub-Saharan Africa with USAID moving this agenda forward to help people get access to HIV treatment. So that was really important in how I visualize things in terms of the world. But at some point I said to myself, you know, I have to come back to the US, have family, wanted to, you know, really invest in our communities locally here. So I did come back. And I started working full-time in academia, but also working very closely with community-based organizations and doing a lot of HIV policy work. So that picture right there is with former Marty Walsh. You see Ken Mayer, who's the head of the Fenway Institute, my predecessor, Rita Nieves, and just lots of people who do a lot of the core HIV work here in Boston, and leading some of the work with getting to zero and ending the HIV epidemic. And then a lot of this work just, it naturally flowed into COVID. You know, 2020 hit, a lot of the things that I was doing, it was naturally, you know, sort of related to a lot of the community engagement work that we were doing, dealing with and managing vulnerable populations and marginalized individuals. And eventually I was asked to, you know, lead the Boston Public Health Commission, which I have to say, I didn't say yes first. That's a tough job. And it took a little while for me to wrap my brain around all that needed to be done, you know, especially because it was actually July of 2021 when I was appointed. And, you know, right around there, we were talking about the Delta wave and the surge and everything that was going on. And finally I decided that this is really what I want to do. This is what I want to invest in. This is what I want to use all these years of work to channel. And I think that it was the right time and place for me. So as I look back though, oftentimes when I talk to students, they ask, well, so how does this whole international thing blend with the local thing and the domestic thing? I mean, these are different sort of worlds. Well, the way I look at it is much of what I saw internationally in sub-Saharan Africa was structural violence. Okay, and structural violence really refers to the multiple ways in which social, economic, and political systems expose populations to increased morbidity and mortality. And to me, that's very much so interconnected and interrelated with structural racism. And you probably know that there are lots of very long definitions of structural racism, almost difficult for you to really grasp sometimes. I keep it simple, and this is actually my definition. A system of hierarchy, privilege, and power that excludes non-white individuals, perpetuates racial inequity, and leads to poor health outcomes. That's essentially structural racism. So when I look back at some of the work that I was doing, I was primarily in Durban. And here you see, this is a suburb outside of Durban, primarily white. And then this is a township, and it's in Umlazi, and primarily Black South Africans live there. Okay, so you see clear inequity. But this is Boston. And so that's Back Bay, you know, that's 76% white. And then you have Roxbury, and that's about 56% Black, 34% living below the poverty line. It's not so different, it's interconnected. I mean, we're talking about degrees, but I think understanding how structural violence and structural racism play out globally really help in terms of developing interventions and thinking about how we can actually contribute to what's happening, not just here domestically, but what is occurring throughout the world. So thinking about Roxbury and thinking about what's actually happening in Back Bay, life expectancy is another area where you see extreme disparities in Boston. So you all probably remember this report. It came out in 2012, those of you who are faculty members. And essentially what this group found was that there was a 30-year life expectancy difference between the census tract in Roxbury, where life expectancy was about 59 years of age, and a census tract in the Back Bay, where life expectancy was 92 years of age. And so a lot of work was undertaken to try to do something about this. Not systematically per se, because I've talked to people who tried to figure out exactly what happened here. We would like to actually, and we're working on actually replicate these numbers, to actually update them and see exactly what's going on. Because I think some things have shifted. There's been gentrification, there's been a lot of movement and construction in and around Boston. Neighborhoods aren't exactly what they once were. If you all are from Boston, you probably know this. But what we see now, and this is just by zip code, so that was census tract, this is zip code, these are neighborhoods. The lowest life expectancy in Boston by zip code neighborhood is really Mattapan at 76.5 years, and that's going down. As we know, across the country, life expectancy is going down largely because of COVID, but other factors also play in here. And then you see Beacon Hill and Back Bay, life expectancy, the average life expectancy about 86.4. So still a significant difference, but nowhere near where it was before. Once we get the census tract data, I think that'll be much more illustrative of exactly what's happening. But I think it's important to note the racial and ethnic disparities. If you look at the average life expectancy across Boston, it's 81, but amongst Black males, it's 71 years of age. And this is something that we see across the country, but it's important to note that we see the same things here as we see everywhere else, even though we oftentimes think, oh, well, Massachusetts, Boston is very progressive, we have this, we have that, we have resources. We still have this problem. So I think we're all aware that the examples I gave are just part of what we see in terms of structural racism and structural violence. There are many manifestations. So this is the 1936 FHA redlining map. You all know this is the history of Boston in terms of residential segregation. It has ramifications in what we're seeing today. This is Suffolk County Jail. I was just there recently. Essentially 46% Black, 25% Latinx. A lot of this is going to relate to a story I'm going to tell in a bit about substance use disorder and homelessness in Boston. We know there's xenophobic immigration policies. And then how many of you have seen this picture in the corner up here to the right? Okay, yeah, so this is 1976. This is busing, school desegregation. And that looks like a young man who's like almost impaling a Black man with this flag. Actually, I think the story is probably a little bit more complicated, but it's a very profound picture. You know, this really talks about, speaks to the anger. It speaks to the divide between people. You know, and this is right here in Boston. And of course, there's been changes, but we all know that there are issues within BPS, within, you know, the educational system here in Boston in general. Okay, so public health doesn't necessarily, you know, run all of those issues. I mean, it's not like it's just on public health to deal with the issues that I just relate to you. But public health really plays a central role. And it's really what we look at in terms of looking at, you know, health outcomes and what is it that public health infrastructure can do to contribute to improving those circumstances. So then the question is, how are we funding public health in the United States? Well, this is total health care expenditure in the United States in 2020, $4.1 trillion. In 2020, the percentage that went towards public health was 5.4%. Only 5.4%. And that's actually high, and that was high because of COVID-19. Prior to that, 2019 was less than 3%. The number that I saw was actually 2.4%. Okay, so we're really talking about a minuscule amount of money that goes towards public health, and that's concerning. How does that manifest itself? Well, emergency preparedness funding has declined significantly over time. This is funding to the CDC. And this is what we see at the Boston Public Health Commission. Our Office of Public Health Preparedness is funded by grants. It's not even really funded primarily by city appropriation. We just don't have the money. We're working on that because it's something we have to change, but this is the problem. If you don't consistently fund something, you're never prepared when an emergency occurs. And then what about infrastructure? So the most important part of public health infrastructure is our staff. It's our people. They are the most valuable thing that we have. And we have to nurture them, and we have to keep them employed. We have to retain them. And here we see that essentially over the past decade alone, the public health workforce has shrunken by more than 15%. About 47% of people do plan to retire or leave the public health workforce in the next 5 years. So we have a problem here. And if you look at the Boston Public Health Commission, currently we have a vacancy rate of about 15%. We have a lot of open positions. If you are looking, please check out. Talk to me afterwards. We are working on many things. We're working on increasing salaries, benefits, professional development opportunities. So it's something we know is a problem. So if you have time at all after this, I would take a look at this commentary in health affairs, because the question is why? What is going wrong and how can we change it in terms of this devaluation of public health? So the authors of this commentary basically put it in two buckets. So there are cultural challenges and there are political challenges. Now you might know National Public Health Week, I think the theme is about cultures and going across cultures. There's many different cultures around in the United States. So when you say cultural challenges, what does that really mean? They're really talking more about the cultures of our institutions, the cultures of our systems, what it is that we as a nation allegedly believe in. So the problem with public health is that we as a nation believe in individualism. We don't believe in collectivist thought. Remember when everybody was talking about everybody wearing masks, right? And then you got the backlash because they're like, I don't care about so-and-so's grandmother, I care about me, you know? Well, now, when you really think about how people think about each other and about community, it's really very individualistic. We don't think about prevention. We think about treatment and cure, and that's the medical world. That's hospitals, that's clinics. Public health really focuses on low-tech solutions. We're not worried about which iPhone you have. Okay, that's public health. We know we're underfunded. We know we're trying to reach folks who may have been made vulnerable. We want to get them the solutions and get them quickly. We're not looking for something high-tech necessarily. And then there's this interesting premise they put forward, which I believe, but I don't know, you may not feel this, but oftentimes people think public health is not a public good. It's a good that is for the marginalized. So it's not for everybody. So therefore, if it's just for the marginalized people, it kind of goes back to this issue of individualism. It has nothing to do with me. So why do I care? Why should I invest in this? Okay. And then there are political challenges. So I didn't give you the overall definition of public health. It's very broad. If you look at WHO or BPHC or any organization that's trying to define it, it's very broad. And what I've learned in my 2 years in this position is that if I'm not saying something crisply and clearly, I'm not getting anything accomplished. Okay, because you have to be able to tell people what is it that this is, why is it that you want funding for it, and how much you want. Okay, that's how politics works. And then there are these unpopular interventions like masking. I have to tell you, I still get hate mail about masking, particularly within BPS. I mean, crazy, not just emails, like notes. Are you serious? Unpopular interventions. This lack of revenue generation. We don't even have like development funds really. We don't look for donors necessarily. We probably should, but we don't, you know. And then there's this lack of political influence. So let me ask you a question. The AMA and the AHA, American Medical Association, American Hospital Association, in 2022 spent $48 million to lobby Congress in 1 year between the two of them. How much did the American Public Health Association spend? Anybody? Okay, the faculty members, students, any number. What do you think? Just guess. 5 million? Okay. 0. Who said zero? Raise your hand. It's closer to zero. Okay, it was $119,000. I mean, they basically paid for somebody's salary and had them go and talk to the legislature. That's what happened. Okay, that's a problem in our world, in our country. Okay, it doesn't work. Our system doesn't work like that. I mean, we work utilizing political influence. We could argue about that. Certainly, I don't necessarily agree with that, but that's how it works. And I didn't even count in the pharmaceutical industry. Okay. Think about what they're spending. Okay, so let me turn to addressing racism and inequity in Boston, because I do want to give you a few examples and then turn it over to my colleague Triniese. So I think that one of the things, as I said, we want to do is reimagine, strengthen, center public health in Boston, and really with a focus on addressing racism and inequity. So let me give you a couple of examples. So this is Massacas, the area around Massacas. And so this is actually an aerial view picture taken before December of 2021. So before that time, you will probably, watch or drive past, these little blue triangles, these were tents. This was the sort of moderately sized, it wasn't even really that big comparatively speaking, but moderately sized encampment that we had on Atkinson Street and then New Market Square. And so the people who lived in these tents, substance use disorder, co-occurring mental illness, other chronic diseases, and many had lived there for many years, because when Long Island was closed, and so those of you who know Boston, Long Island was closed, there wasn't always a place for people to go. And then you had the rise of fentanyl. So you had more people who were using, drug dealers are stationed in these areas, and then you had COVID-19. So the confluence of all that led to this. And so this encampment was characterized by high rates of violence, violent crime, victimization of both men and women, human trafficking, and overdoses. And there were periods in Boston's history over the years where this was more of a criminal justice issue. So it was really more leaning on BPD to deal with this. And that's true of, just sporadic periods where it wasn't so much anybody else, it was really BPD. So what we did in terms of recentering and strengthening public health and building infrastructure was that we made this a public health crisis. Okay, so this is public health that needs to drive this. Not to say we don't work hand in hand with BPD. I talk to the commissioner all the time. I mean, he's like my buddy when it comes to issues like this. Certainly working with housing, certainly working with City Hall, but really the philosophies related to public health are driving what's happening here. And I'm not saying we fixed anything, but what we did do was we got people housing. So instead of closing the encampment, which other cities have done, just closed it, just people can't be there. We said, you know what, we're going to open 6 low threshold housing spaces. So low threshold means you don't have to be you don't have to be in recovery. You can still use. You don't have to necessarily participate in anything. But what you're doing is you're saying housing is first. Get people that first thing that they need, and then try to engage them in other services and get them on a path to recovery, hopefully. So we invested, and I honestly really appreciate Mayor Wu for pushing this along. We really invested an enormous amount of energy, effort. At some point it was like blood, sweat, and tears to get this program up and running. And it was really one of my first sort of assignments with Boston Public Health Commission, with Dr. Monica Burrell, who was the former Commissioner of Public Health, with the Mayor's Office of Housing. It was a lot of people, and we all put forth the effort to get people out of those tents. And by January 12th, most of those tents, in fact, all those tents on January 12th were gone. Now, some of them have come back. Fentanyl's not gone away. We still have issues. But those 2 encampments, at the size that they were, don't really exist anymore. So what does this have to do with inequity and structural racism? Well, the picture of opioid use in general tends to be white. That's the picture in the media. That's, sort of how it's portrayed. And we can talk about, why that is and what that's done in terms of funding, in terms of political influence that's generated. But 61% of people on that Massacas area, in that quarter-mile area, were actually people of color, 30% Black and 31% Latinx, probably about 20% Spanish-speaking. And we know that structural racism drives the disproportionate burden of substance use disorders amongst people of color. We know that there's a limited availability of medication for opioid use disorder. We know that there's been an increase in overdoses amongst Black individuals. So then we have to think to ourselves, when you implement a program like this, think about it, when you implement a program, oftentimes, unless you are intentional about health equity, unless you're intentional and make sure that you are measuring, that you are monitoring, that you are evaluating what you're doing as you move forward, you will likely have disparities. Okay, so that is what we are trying to avoid. So luckily, Congresswoman Ayanna Pressley and Senator Elizabeth Warren were able to get us 3 years of funding. So we're making sure to ensure equity. We're working with post-incarcerated individuals. We're decreasing substance use stigma, and we're planning for sustainability. So just very briefly, I want to say that another example is mental health status. So we know that there are disparities in self-reported mental health status. These disparities have been exacerbated by COVID-19. We know that there's a lack of racial, ethnic, cultural, linguistic diversity amongst mental health providers. So what did we do about it? Well, we opened a Center for Behavioral Health and Wellness, and we used our ARPA funds for that. We also hired the first Chief Behavioral Health Officer in the city of Boston. That's Dr. Kevin Simone. Most cities do not have that. And we said, you know what, we're gonna make mental health and we're gonna treat preventing mental health crises as a true public health crisis. You know, we're gonna take this seriously, and that isn't done everywhere. So our 3 objectives: 1, we're working on widening public awareness and addressing stigma. We're actually developing a pipeline of behavioral health clinicians using about $5 billion. And then we're gonna strengthen training of adults who particularly work with youth, and that's within BPS. And that's obviously quite needed. Okay, so let me start to talk about our last example, the Declaration of Racism on Public Health, and then I'm gonna turn it over to Triniese. So this is the history, sort of the Boston Public Health Commission. And if you didn't know, let me tell you, it's the oldest health department in the country. And this gentleman, Paul Revere, not only took his historic ride, you know, gallows, and was born in Congress. He was also a dentist, he was a coroner, he was an early advocate for infection control, and he was our executive director in 1799. Okay, so who knew? I didn't know myself. So okay, organization. Over time, you know, there's been a wealth of wonderful things that have happened within this public health department, and people like John Auerbach, who was a faculty member here, have led some of this work. You know, Barbara Carrere, who's now out in LA, great example of leadership, you know, here in Boston. And a lot of this has been racial justice work, but it really wasn't until 2020 that racism was declared a public health crisis. And I have to give all credit to those who advocated for this at that time. I wasn't at the Boston Public Health Commission, but certainly watching this from afar. Mayor Marty Walsh, in the wake of Mr. George Floyd's tragic murder, he declared racism a public health crisis in Boston. Okay, but what does that really mean? I mean, I'm kind of a cynic, so I'm like, the American Public Health Association basically said it very bluntly. The declarations themselves are often symbolic, but what has impact and creates change is turning advocacy and symbolic gestures into action. So then the next question should be, did we turn it into action here in Boston? Mayor Marty Walsh had a commission, they did 8 strategies, and that's great to have 8 strategies. I think probably there may be faculty members who are part of this commission, and it's a great document that you can take a look at online. And he actually did something unlike the other 200 or so cities, jurisdictions who declared racism a public health crisis. He actually allocated dollars to this. So I'm going to turn it over to Triniese Polk to tell the story, because I wasn't there, she's there. She moved a lot of forward, and to talk about how we strengthen public health using these dollars.
I know what I'm doing. And he is back in. Okay. So first, thank you, Dr. Ojikutu. And I have to say that I don't usually call her Dr. Ojikutu. She's Dr. Bisola or Dr. B to me with my permission, so I just wanted to be transparent in this meeting. But hello, Northeastern. How are you? We're gonna try this again. Sometimes when I put my glasses on, I can hear better. Good afternoon, Northeastern. See how that works? Amazing. So I'm a Boston native, Boston born and raised, and I have been admiring Northeastern somewhat from afar for quite some time, right? I drive by frequently, I walk by and I kind of peek in and window shop a little bit. And today when I step foot on campus again, right, it's my first time knee deep, from my perspective on campus. I was like, I'm gonna make pretend. Am I a student or a professor today? I chose student, assuming students are having way more fun, but I could be wrong. I don't know. So again, thank you so much for having me. As I am sharing our story and our journey that we have been on, our racial equity and justice journey that we've been on for quite some time, I will be referring to the Boston Public Health Commission as BPHC. So I just wanted to share that with you so I don't lose or confuse you along the way. And as Dr. B shared, I have shepherded a lot of work within BPHC, so I had to write it down, just so I don't leave anything out for you. So Boston, as you know, I've shared, is a beautiful city. And again, I know this because this is where I was born and raised. It's well known for its state-of-the-art hospitals and top-notch medical care, sought-after schools and universities and economic opportunities. However, as Dr. B mentioned, right, not all residents are experiencing Boston in a way that they should be. So that, Boston's most valuable asset is the residents of Boston, the diversity of cultures and traditions of the people that call Boston home. And as I shared, unfortunately, not all residents experience what our beautiful city has to offer equitably. There are varying disparity reports that reveal historic racial wealth and health gaps here in our city. And the Boston Public Health Commission, we serve everyone, but particularly those individuals who are in most need. And we envision a thriving Boston where all residents live free of racism and other systems of oppression, to have the ability to live healthy and fulfilling lives. So Pink and Black, this is one of my fondest. You're going to hear me throughout this presentation. I'm going to be bragging about every last one of them because I get excited about every initiative that we've done. But this is one of my most fondest. In the early 2000s, in response to identified local-based racial health disparities, Boston City Hall, then Mayor Menino, and BPHC established a citywide health disparities task force that was led by BPHC and local hospitals. And through that former task force, Boston's Pink and Black campaign was born and gave both national and local recognition for drawing attention to the stark differences in health outcomes between white women and Black women. Sadly, several of the women on this poster that you see today did not survive their battle with cancer, and I supervised one of those women. Ms. Carmen is the reason I get my regular mammogram every year without the hesitation I once had prior to meeting her. My conversations with Ms. Carmen would often go something like this. Triniese, and I would take a deep breath because Ms. Carmen was sweet but stern. Did you schedule your appointment yet? No, Ms. Carmen. And why not? Ms. Carmen, as I've told you time and time again, I heard that it hurts. I've heard that the machine is big and cold. And what if I get bad news? And Ms. Carmen would say, well, I've told you time and time again. First of all, it doesn't hurt. It's barely a pinch. And yes, the machine is big and cold, but you live in Boston. What are you whining about? And only if you get bad news. Triniese, we would have caught it early enough to turn the bad news into good. So I love to share that story with you because representation does matter. And Ms. Carmen, to me, was like the auntie who wasn't blood related, if you know what I mean. So from Boston's cancer disparities work, BPHC began to build its foundation to support its commitment to racial equity and justice. We established a dedicated Office of Health Equity. We established our vision statement, our health equity framework, mandatory all staff training, and equitable community engagement policy and plan. What you see here is our health equity framework, and we use this to illustrate how racism as a system impacts our access to quality health promoting resources like employment, all the things that Dr. Bisola mentioned, employment, housing, and healthcare and education. And as you know, we refer to these resources as social determinants of health, just making sure, right? Public health lingo is the public health lingo that we need to make sure that everybody else understands.
And also, as you know, when money, power, and resources are distributed unfairly in these areas, it leads to poorer health outcomes like diabetes and the cancer example that I just shared with you. So I'd like to point out that BPHC is race explicit, but we're not exclusive because we know that individuals do not live a one-dimensional life. Identity discrimination, including gender, age, and sexual orientation, also impacts our access to and quality of health promoting resources. So I'm certain that everyone in this space would like to, I know professionally and personally, I would like to have a do-over for 2020, right? The year of 2020 was a year of unprecedented events. And just like many other public health departments, BPHC had to roll up its sleeves and do the work to address two crises, racism as well as COVID-19. So after the release of Boston Racism Declaration in June of 2020, we used our equitable community engagement framework to learn from staff as well as residents from their point of view, what a Boston free of racism would look like. And so staff and residents, including our racial health equity advisory committee that you see here to the right of the slide, said that Boston has some work to do, right? So despite all of the great work that we've done and we have accomplished over the years, we still have some work to do. And the first and best place to start is for us to address the racism or dismantle the institutional racism embedded within our policies, our practices, and our cultural norms. So per community request, my team and I lead BPHC to build on its foundational work and to center anti-racism in every corner of our operations. So to the left of this slide, you see our community engagement framework. We asked the community said, we did, and now I'll walk you through what's changed at BPHC. So we changed the former office name of Health Equity to the now Office of Racial Equity and Community Engagement that I'm overseeing. And that again helps us to be more intentional because as Dr. B mentioned, if you're not intentional in your address to racism, it's one of those things that you can easily overlook and it just continues to perpetuate itself. So we established BPHC's first of its kind anti-racism policy and action plan for all departments to take to address institutional and structural racism. So for example, our budget equity tool is used by all departments to prioritize spending for equity in neighborhoods and populations that are most in need. Managers are required to describe how their budgets requested help to advance achievement of racial justice and health equity. And we've advanced our tool requiring departments to incorporate community voice through participatory budgeting. And see, that's really important because remember the previous slide I showed you about community engagement. I'm definitely under the belief that without community voice and decision making, we may be doing a disservice. So it's really important for the community to have a say in how we're spending essentially taxpayers' dollars from my point of view. Our equitable procurement policy required departments to obtain free quotes when seeking goods and services above a particular purchase amount. And at least one of those quotes must be from what we refer to as a Q, a certified underrepresented business. And essentially that's a minority owned business here in the city of Boston. We're overhauling our professional development plans by updating our all staff racial justice training to an anti-racism content-based curriculum, including how to collect and disaggregate data. And without disaggregated data, it's difficult to know how we're serving individuals, and it's difficult to know who we're not serving, right? And who we might be missing and how best to serve. Staff will also learn how to identify and counter implicit and unconscious bias in interaction with decision-making. And upon completion of training, departments will be responsible to the learning by establishing racial equity action plans. And all of the plans will be closely aligned to the commission's strategic. Something that I get all giddy about. Most recently, we launched a DEI training for our 20+ member senior leadership team, which also included pre and post work requirements to support accountability in their learning and action. And an action that I get just as giddy about. I told you I'm going to be saying everything I get really excited about. We embedded anti-racism and racial equity duty requirements in all of our job descriptions. To decrease incidents of implicit and unconscious bias in hiring, we're piloting the use of diverse interview committees and standard equity questions in scoring rubrics. and making adjustments in position requirements to make sure that we are not leaving anybody out. We don't want to miss any great talent within the city of Boston by having like this requirement or expectation of high degrees and so on and so forth. So that's really, really important to us. And to support a culture of belonging, we established employee resource affinity groups, and spin-off of the groups are a cultural planning committee. And so we hosted for our very first events such as Latinx month and our very first Juneteenth event. And so we're really, really excited to continue to celebrate all the diversity that's within BPHC. And I have to admit, Dr. Bisola is amazing when she says Triniese does a lot of great work, but sometimes I'm like, oh boy. I want to slow down a little bit, but this, the planning committee, this went over so well that the staff said that we have to continue to do it. So although last year was the first year and I was thinking, okay, people might not buy into it as much, they totally bought in and they said, Triniese, you have to keep doing it. So we're gonna keep doing it. And the committee, it expanded in size. I think last year it was like 6 people and this year we have like 20 plus. So that's a bonus. So something else I get really excited and proud about. So continuing in the theme of creating a culture of belonging, I would be totally remiss if I did not acknowledge our consortium for professional development department. They launched a 6-week emerging leaders pilot, which aims to improve leadership diversity. And upon completion, our students received a certificate from Harvard University. And so you see here a picture of our first cohort, and my staff, my associate director is in this photo, and I love to brag and show her off because I like to think that we're preparing her to someday have my job, or at least perhaps something even greater. So last year, we engaged staff in a process to identify organizational core values, and I wasn't surprised, and I don't think that very many of my coworkers were surprised that anti-racism and racial equity was anti-racism and equity were at the top, you know, leading 2 out of the 5 of our core values. And so these are definitely going to be landing in our job descriptions as well as requests for proposals. And the reason for the request for proposals is because we want to ensure that the folks that we are partnering with, particularly contractual relationships, their missions and their values align with ours. So to what, you know, the story that Dr. Bisola was sharing earlier, it's a system, right? And we can't do it alone. So we want to make sure that we're bringing everybody along as best we can. So we're not in denial of the challenges that comes with doing racial and social justice work here in Boston, and how difficult it can be to stay on course. And we see an overhaul to our employee journey life cycle as part of a plan to hold ourselves accountable to our anti-racism commitments, where we will hire those that share our commitment to advance anti-racism in our company core values. We will reiterate such commitments in departmental and individual work plans. And we will continue to invest in our employees and have the events like I just shared, right? The Juneteenth and so on and so forth. And we will praise and reward employee accomplishments and demonstrated commitment to goals and core values through a performance evaluation tool. And of course, we will continue to collect community feedback, staff feedback, so they can help us improve as we're moving things along. So I know I've been saying all this time that each initiative or each innovative idea is my best, but this, or my favorite, but this is my absolute favorite. We just, I promise, but this is my absolute favorite. This is, you know, I've shared with you what we've been doing internally, and all of that is absolutely necessary. As my grandmother always says, she's like, you have to sweep or clean your own front porch before you go trying to sweep or clean somebody else's. So I'm extremely proud of all the work that we have been doing internally, but we have to go outward facing as well, right? And so what we've done with some of the resources that Dr. Bisola mentioned earlier, we started a generational health scholarship. So we're really, really looking forward to partnering with local-based universities and community-based organizations to offer BIPOC students the opportunity to achieve a 4-year degree in areas of public health and mental health, all those areas that are under, you know, may not have the best representation of people of color in them. So this one gets me really, really all giddy. So as I begin to wrap up, I want us to review one of my very favorite quotes from Toni Morrison. As I said, I had to really, writing this down made me remember like all of the things that I have accomplished since I've been at BPHC. My introduction to BPHC, I often refer to as my happy accident. Prior to learning or achieving my first entry-level position, I thought I wanted to be a medical assistant. And then I said, no, I'm gonna grow from the medical assistant and then I'm gonna be a pediatric nurse. And then I quickly realized from being a medical assistant at Harvard Vanguard that the sight of blood made me nauseous. And the screams of sick children and the snarls of their sleep-deprived parents wasn't something I could quite get used to. So I stumbled upon BPHC while I was at a job fair, and well, here I am 20 years later. My fight against racism is both personal and political. My family and I were once recipients of the resources that I advocate for in my work. My professional success and generational first aren't a result of my ability to pull myself up by my bootstraps, but instead a result of access and opportunity. Without a shift in how we use our individual and institutional power, racial inequities will continue to persist. My presence here today demonstrates that Northeastern shares the sentiment. Thank you, students and faculty, for your stand against racism. The saying goes, if you don't stand for something, you'll stand for anything. I know firsthand how challenging this area of work can be. Believe in your work that in this fight, if it doesn't feel hard or uncomfortable at times, you're probably not doing it right. And as I say always, if you haven't joined in the fight just yet, and perhaps you're unsure of where to start, think big, but start small, and please take your time and hurry up because we Thank you.